Hello out there in television land, and welcome to yet another edition of It's Your Health, the fastest 30 minutes in television history. Philip Benyo with the Fipster, bringing you the latest and greatest in healthcare information. We'll be right back after this brief commercial message. Make sure you check with your healthcare provider before doing any of the things that we talk about here on It's Your Health. We'll be right back. Welcome back to the first segment of It's Your Health. We're going to go through a whole plethora of information out there. I just want to make an announcement that in January I'll be celebrating my 65th birthday. And I know there's an urban rumor going out there that I'm retiring. There is no truth to that whatsoever. I'm going to continue to work until I'm at the funeral home. Who would not want to work with their two sons, Philip, and of course my other son Daniel, who recently joined our practice. So retirement is not on my wish list or New Year's resolution. That being said, Phil.
Well, let's talk about some New Year's resolutions and maybe statin use and smoking. Statins cut COPD deaths.
That's unbelievable. It's a cholesterol medicine, right?
That is true. That's right.
Tell us a little bit more how this happens.
They actually looked at patients who were recently diagnosed with COPD, and if they started on a statin within 1 year, they actually cut their all-cause mortality 21% and their COPD or pulmonary related mortality by 45%.
That is unbelievable. And again, I like statins. They're anti-inflammatory. There's issues, maybe it reduces the risk of some cancers, to say nothing of cardiovascular and stroke risk. So
certainly a great reason to be on them, and that's kind of the role they think it plays it plays some role in decreasing the inflammation. We always used to think it was just kind of in our heart, but we've shown some studies that actually reduces inflammation in your GI tract and now in your lungs.
Wow.
Moving on. H. pylori screening didn't reduce dyspepsia risk.
What does that mean?
Well, I never actually consider screening for it routinely, but in some circles they actually screen for H. pylori, which is, as some people know, H stands for Helicobacter. This is a bacteria that lives in your stomach and create all kinds of problems for people who get this infection. Sometimes it can just be GERD, abdominal pain, but it increases the risk of certain types of GI cancers, so it certainly requires treatment when it's discovered. We usually see it discovered on a routine endoscopy when someone's having GERD symptoms and we look and find this evidence of this bacteria. There are some screening tools out there. However, it really doesn't look like it actually helps reduce the risk of anything by blanketly screening everybody for this.
So when in doubt, take it out.
Many years of metformin linked to an anemia risk.
Yeah, that's kind of interesting. Metformin, of course, is the go-to drug for type 2 diabetes, and people will be on that first line for many, many years, and we're finding their low blood counts.
Yeah, there is a slight risk of, it's about 6% of people who take metformin. For every year they take it, their risk goes up about 6%. Certainly this is one of those benefits outweigh the risks. Metformin is an extremely safe medication. It's been around for a long time. It's very important for our first-line diabetic. It's also very inexpensive, which helps because diabetes is an expensive disease state, and so metformin helps cut that cost. But it's certainly something to think about when we're starting to see someone that has some anemia. I certainly always like to look and see, well, what am I doing to cause this? But I don't think about metformin.
Sure. Well, we will now. And it's not necessarily related to B12 absorption, iron, or anything like that.
They actually do have no clue.
No clue.
It's just conjecture at this point, which is what you're doing.
Keep listening.
We'll figure it out. All righty, let's move forward. Now, a lot of excitement. Let's first talk about shingles. We usually see this time of year. As we've talked about plenty of times, shingles is a painful condition. It's one side of the body. There's a picture there that shows a common case of shingles. Usually when it gets to this point, you're kind of in trouble. We have to use some medications to help slow the course and maybe help cut down on the pain, but that pain can be long-lasting and a lifetime.
Right.
Over the last few years, we've had a vaccine that we use to help decrease the incidence of shingles. It's not perfect. It's only covered in people's, although it's approved 50 years and older, it's only covered by insurance 60 years and older. It's like a $300 shot. But we've had some people actually have had the vaccine and got shingles. Not from the vaccine, but they just happen to get shingles.
Vaccine
but there is a new answer.
There is a new vaccine on the market for shingles. It's been approved. It is a 2-shot vaccine, and I'm not sure it has to be reconstituted at the pharmacy. This may be something available in the office one of these days. I think we have to look into that. But nevertheless, it's supposed to be new and improved for shingles vaccinations.
It's approved for people 50 years and older. It is a 2-stage shot. Has a much better efficacy than the current vaccine. In fact, in its short tenure already, the CDC and the main boards have suggested that we use this over top of Zostavax. So I think we're going to see Zostavax, which was great because that's all we had, but now we have some other options. We're going to start seeing Shingrix used much more commonly. So looking forward to seeing how that works out. Although it's approved, I don't know that it's yet available here, but it should be shortly.
Keep listening.
All righty. So let's talk about subclavian steel.
Yikes. Is this an illegal type of thing if someone has stolen something?
So if you look at this picture, you'll see that there's something that just doesn't make sense. There's one side that's lit up very nicely and the other side that's not lit up very nicely. And in these patients, sometimes we see dizziness. This is not a condition we think about very often. It's actually one that we see by accident, but we recently had exposure to a patient with this.
Right.
Talk about
the subclavian artery kind of comes off the heart, and one of those branches goes up into your brain, into the dizzy center, and if there's a blockage, the subclavian will steal blood, hence the name, subclavian steal syndrome, will steal blood from where it's supposed to go up into your head and create some neurologic symptoms. Believe it or not, if you just check the pulse on one side or another, there's a difference in the pulse and the blood pressure. That's sort of a tip-off to this, but it's a correctable type of thing. Some people thought they were crazy because they couldn't find out why they were dizzy, and here they had subclavian steal. So keep looking, as we say in medicine.
It's certainly an interesting thing. We don't see it I think maybe I've only seen it twice in my career. Moving on, this is actually kind of a fun picture. We do see this from time to time. People come in with all various kinds of skin lesions. And here's a picture of a little horn. Sometimes these will grow on their shoulders. Sometimes they'll grow on ears. Sometimes people get really disturbed by them because they look like they're growing horns. Have we seen these before?
It is a horn, and the last one I saw was coming out like a devil, if you will, and it disturbed the person. They're benign. If you remove them, they tend to come back because they have a deep layer. What we generally do is numb it up and take out the base, and you'll never hear from it again. Of course, we'll analyze it because no one really knows whether it's cancer or not. I recently had a fellow who had something on his finger, and it, for all the world, looked like a cyst. And we were going to let it go, but something told me to take it off. And here was a basal cell cancer. So you never really know what you're dealing with. And I think the take-home message is if you have a new lesion or a lesion that's getting worse, if you will, you really should get that looked at.
Yeah, cutaneous horns, if people try to pull them off themselves, they can get infected. In this actual case report, this person ended up having a cancer at the base of it and required further excision.
Wow.
So nothing spooky like a melanoma, but something that was readily taken out. But we do see these from time to time.
And on that note, we will take our first commercial break. Remember, you're watching It's Your Health, your leader in healthcare information. We'll be right back. Welcome back to the second segment of It's Your Health. Philip Benyo with Fipster, bringing you the latest and greatest in healthcare information.
What was our lead-off headline on the last segment?
If I recall, it was something to do with statins cutting down on lung disease.
Right. How about statins use to cut risks in compensated cirrhosis?
That's hard to believe because one of the things that we do when we put people on statins is we measure their liver function tests, and if they get bumped, we kind of say, well, maybe this drug's not for you. So you kind of say to yourself, we're going to use it in someone who already has known liver disease?
Well, they have shown that, we'll see a 27% drop in portal hypertension. You can see about a 46% drop in progression from compensated cirrhosis, which means cirrhosis you're living with and getting by, versus decompensated cirrhosis, which means you're in the hospital and you're getting ready to die. And there's all kinds of other risks. Portal hypertension, that's when we start getting varices, we start having bleeds, and how these people kind of cool pretty quick. But statins actually have helped decrease the role of inflammation, and also in part some of the fatty deposits that we run into with certain types of cirrhosis.
So yet another indication for statin use.
And again, a place that we would never think. In fact, we'd stay away from. I used to think about, oh, you have cirrhosis, we better get off that statin. But this is actually shown to help you live longer with this condition.
Yeah, we've actually had a couple of patients who had non-alcoholic fatty liver. And we put them on a statin, and lo and behold, their liver function tests went back to normal. So perhaps on the same basis.
Intensified approach to cut long-term heart failure risk in diabetes has proven effective versus more conventional heart failure treatments.
What do they define intensive?
Well, that we really have to manage not only their diabetes correctly, but they go on the full regimen of medications that we use, beta blocker, ARB, salt-restricted diet. That in diabetes, heart failure is something we don't think about as a problem, but once they start having that problem, we're really behind the 8 ball, because diabetes really affects these small vessels, and they kind of block them off, and once they're kind of done, you're done. And as it starts to affect your heart muscle, we really get in trouble. And so it's really important that we intensify and really treat aggressively heart failure in diabetics.
Right. And one of the things that I found out over the past year is a release of a medicine called Entresto, which has really cut down on readmission rates for heart failure. Getting the insurance company to pay for it has been sort of one stumbling block. But in people who have tried that, we've really had quite a lot of success. Entresto for heart failure.
All right, that's true. I agree. Time to abandon fasted lipid profiles.
Yeah, it's kind of interesting because when we asked people, we're going to check your cholesterol, they'll say, hey, wait a minute, I didn't fast for the 12 hours. And I try to remind them that you don't live life fasting 12 hours. I want to know what your cholesterol is at 2 in the afternoon. And so I don't know if this buys into that or not.
Well, kind of, we'll get the screenings done more often. We'll capture a lot of people who wouldn't normally get blood work. And the really only ever need for true fasting lipid profile is for triglycerides. Your LDL, your HDL, your total number doesn't really fluctuate that much, but triglycerides, which are the transport molecule for fat in your system, those do fluctuate greatly. And so if you suspect someone has really high triglycerides and you're going to treat that as an independent problem, then we should get fasting blood work. Otherwise, a non-fasting LDL and HDL, that's really all you need.
Right.
You can throw the total cholesterol in to get a clue as to what those triglycerides are doing. Sometimes you can tell if someone's triglycerides are high merely by looking at the tube. Blood normally looks rather bloody, but when you look at someone's blood whose triglycerides are high, it looks like a vanilla milkshake.
There's wax on top.
And actually, they have a thick fatty layer that's measured in inches on the top of their spun blood, and that's usually a sign that, like, oh, we better get some fasting blood work on this guy, or he just had a Big Mac. Who knows? But that's certainly, unless we're looking for high triglycerides, it really is not important for us to do fasting lipid profile. Plus, it'll actually save some money because you're not having to do all that extra testing.
Absolutely. Good point, Phil.
All righty. Talking about fasting and weight loss, a lot of times patients come in and be like, well, I don't like diet and exercise. I don't want to take the hard road. I want to go the easy road, and let's take a pill. That's our solution in today's world, is take a pill for everything. Let's talk about the different pharmacokinetics and different meds we have for weight loss.
Right, the pill for every ill. Well, in the olden days, the only thing you could really take is one of the amines that would increase your pulse, your respirations, your blood pressure, and your metabolism. I'm not so sure they are the way to go, to be honest with you. I never was a fan of pills for diabetes, or excuse me, pills for obesity. I kind of say you didn't take a pill to get that way, so maybe you shouldn't take a pill to undo it. And people don't want to do the diet and exercise kind of thing. But there are some newer medications out there that work on brain chemistry that impart some nausea and say, well, I don't feel like eating right now. Is that pretty much it?
Well, here's a little list you can look at. As you mentioned, the first one was phentermine. That's something that still is used. It's inexpensive, effective, but dangerous. I mean, you could have a heart attack on that stuff. It's dangerous. I personally don't prescribe it, although I can. I find it unsafe. It's something I would never consider taking myself. So that's something we really don't do here. But there are people out there that go that route. But You take your first pill, you'll be shaken out of your boots. Second one on the list, Orlistat or Xenical, that's a fat blocker. That actually is very effective and I believe is available over the counter now because it's very safe. You decide to go to Taco Bell and have Orlistat and you block all that fat, you're going to have a party in your pants. So it does cause a lot of nightmarish diarrhea and gas that's not so gassy. So it's certainly not a get out of jail free pass.
We're going to cross that one off the list.
Certainly if you crap your pants once, you may not eat so bad anymore. So it has that secondary effect. Next one is Quizma, which is actually Topamax and phentermine put together. It's kind of a neat little combination. Weight loss people have been using Topamax for a while to lose weight, and there's a combination. Again, we don't use that. Next one, Locasern or Belviq. This is one that goes up in the brain, tells you you're not hungry. When you overeat, you just don't enjoy it. That's the next thing. Contrave does the same exact thing. Tells you Contrave is a combination of Wellbutrin and Narcan, which is what we use to reverse heroin. It's interesting, that combination actually helps prevent people from enjoying overeating. That buzz or that high they get when they overeat, you just don't get anymore. You just feel like crap. So it actually helps. You just don't get the enjoyment. So you get to feel like crap, then you won't overeat. Last one on that list is Saxenda, which is a high-dose Victoza, which is an anti-diabetic medication. Actually increases early satiety. You feel fuller longer. It doesn't allow your stomach to empty faster. Very effective weight loss drug, also very expensive. I haven't had successfully get this covered yet.
So,
or you could just try diet and exercise. That's pretty inexpensive. But
I'm kind of in the eat, drink, and be merry stage of my life. So, what can I tell you? Except we're going to take a quick break here for a brief commercial message. Remember, you're watching It's Your Health. We try to be your leader in healthcare information. We'll be right back. Welcome back to the third and final segment of It's Your Health. It is the fastest 30 minutes, isn't it, Pipster?
oh yeah,
Flies by. So, what are we going to talk about next?
we're going to forego the headlines.
Okay, good idea.
And we're going to go right to. This is something that we run into. It's the end of the year. It's a new year. You have wellness physicals coming up. People are coming in to get preventative cancer screening. And every now and then someone will ask a question, do I need to go for this? Do I need to go for a colonoscopy at 75? Do I need to do breast cancer screening at 85? When do we actually say, well, we've had enough? When's the time to do that?
Well, there are some newer guidelines with regards to that. And first of all, I think it's an individual case-by-case basis. But sometimes the cure is worse than the disease. For example, colonoscopy in elderly patients is somewhat risky. You can perforate a colon and end up with all kinds of issues following that. And same thing with screening for prostate cancer. You can find someone's PSA a little elevated because they're 75. And what are you going to do with that? You're going to biopsy them and subject them to all kinds of risks for something that may not take their life whatsoever. So I think it's a individual type of thing, but the trend that I'm seeing now is that as we age, we need to do more of less, if you know what I mean.
Right. I think at least some of the studies that we're starting to see come out is they're really asking, well, for instance, would we recommend cancer screening colonoscopy on someone that has lung cancer and is on hospice? No, that's crazy. Why would you do that? We expect that person, unfortunately, to live only about 6 months. Cancer screening colonoscopies are past our point. But so what's the cutoff? And so the magic number is kind of to make the decision as to whether or not you feel, given the medical data that you have available, is this person going to live another 10 years? And if they're not within 10 years of their life expectancy, then we screen. But if they're within that, if we kind of do some tests and decide this person's only going to live maybe under 10 years, at that point maybe we're doing too much. So
right.
I know you were reading, but what are one of the things we can now use as a predictor to help decide whether or not we're going to live 10 years or we're going to make it past 10 years?
This is a geriatric test called a gait speed test, where you actually ask a patient to get up and walk, and the speed in which they walk over this short period of length actually is a guideline and can be used as a yardstick and has predictive value on how this person's going to do.
Right. So if someone gets up and they have to use a walker, they have to take their time, they're really having a slow time, and they can't do a 20-foot walk test in a reasonable amount of time, it's safe to say, unfortunately, they're probably not going to live another 10 years. And at 85, that's a pretty good predictor.
Right.
At 75 and 65, that's different. And that's actually a great way to look at all-cause mortality and decide whether or not someone has 10 years kind of left. And if we do that test and they're doing great and it says, geez, this person looks like we've got another 10 years till we're at the 10-year mark, well, then that's someone who we plan on being around for at least 20 years. We should think about cancer screening, because that can come up and get them and ruin their lives.
Right, and this gait testing, again, it doesn't take much of a stretch to see someone who has that disability, that they're a fractured hip waiting to happen. And how many times, Phil, have we seen patients who fracture a hip? Game-changing event, life-changing event. It's a major thing. When you fracture a hip, 2 out of 3 things will happen, and 2 of them are bad. Again, it factors into that, well, I would be doing this much screening if this person is destined for something bad to happen.
All righty. Now we're in the hospital, we're getting that hip fixed. We're 75 years old, and all of a sudden mom or dad is they're losing it. They're pretty good at home, they're not having any issues, they get confused every now and then at who comes in the house. But now they are flipping, they're screaming and yelling, they're carrying it on. It's nighttime, nurses are calling, we don't know what to do, family's upset. What's happening?
Right. Well, they're suffering from what perhaps 1 out of 3 elderly patients who get hospitalized suffer from, and that is delirium. They become confused, belligerent. It's actually a problem with brain chemistry. To say nothing of the fact that they're not sleeping, maybe they're in pain, maybe they're on medications that are contributing to this. It's very common, it's very alarming because it transfers to us saying, well, you guys know what you're doing, mom and dad's now crazy. And that happens very frequently. But the other thing that happens is mom and dad may not necessarily go crazy. They may become what's called hypodelirious. And that is to say they don't act out. They just kind of sit there and don't eat, don't drink. And that actually is more common and has more of death and disability thing associated with it, because they don't eat, they don't get out, they get pneumonia, and then it just kind of spirals out of control. So when we want to get patients out of the hospital quickly, that may be one reason why, because bad things can happen, unfortunately, in the hospital when you're elderly and you become delirious and confused. You try to get up and go to the bathroom and something bad happens. So it's very common. We're aware of it. We try to minimize it, and just fasten your seatbelt. What can I tell you?
Yeah, I tell patients and families all the time, I said, well, we're not really that sick, but if we stay here long enough, we will get sick. And so hospitals they're safe to a point, but if we keep you there long enough, we have a lot of problems. And speaking of keeping you long enough, I thought this was a very interesting study that I think has a lot to do with kind of how medicine is moving and may help see medicine start to take a different turn. But there was a neat study they did, I think it was over 500,000 cases they looked at, admissions to the hospital, and they compared being taken care of by a hospitalist, meaning someone you don't know who just works in the hospital, doesn't do anything else, by your own primary care physician, or someone who's part of maybe a call group, like a generalist. And it had some real interesting ramifications as to length of stay, mortality. What do you think? What do you think?
Well, it dovetails with what we see. And for example, you would not change a quarterback every play of the game. That would be not a successful formula for winning. And nevertheless, what we do in medicine is we have a patient who's cared for somebody like us, who goes into the hospital and cared for by somebody else, and then goes to a nursing home, cared for somebody else again. So you have 3 different doctors in a week's period of time. And I think one of the advantages that we have to offer is that we're going to see here, we're going to see in the hospital, we're going to see in the personal care home, we're going to see in the nursing home. So that continuity and knowing the family dynamics is how can I explain it?
Well, it's just that simple. If you're taken care of in a hospital setting by your primary care practitioners, you will have maybe a slightly longer length of stay, but you'll have less of a chance of dying when you leave the hospital, and you'll have a better chance of going home. We have it on paper. We've studied it. They've studied it. Our way works.
And this way works too, as you've found out by watching It's Your Health, because you're watching, right? Thank you for allowing us to come into your home and inform you, possibly entertain you, with the party in the pants, right?
It's entertained us.
So again, thank you for joining us, and remember to check with your healthcare provider before doing the things that we talk about here on It's Your Health. Thanks for watching It's Your Health, your leader in healthcare information.